Welcome back to the second session on management of drug-resistant TB. In this session, we will look at pre-treatment evaluations and how to monitor the treatment progress, including treatment outcomes. So, what are the pre-treatment evaluations for all drug-resistant TB patients? There should be a clinical evaluation in which a detailed history about patient's symptoms is taken, including treatment with previous anti-TB drugs. The height and weight should be recorded. The comorbidity, especially diabetes and HIV, should be documented. Social habits like smoking and alcohol. The laboratory investigations include complete hemogram with hemoglobin and platelet count, blood sugar, liver function tests, renal function tests, HIV testing, routine urine examination, urine pregnancy tests for women of childbearing age. The additional investigations include chest radiograph and an audiogram. In addition to those baseline investigations, it is important to do TSH because drugs like ethionamide and PAS can cause hypothyroidism. So, it is important to monitor the thyroid function. Mental health evaluation has to be done. Drugs like cycloserine are potentially prone to cause psychiatric complications. Surgical evaluation has to be done for all patients. So, ECG has to be done if the patient will be initiated on treatment with shorter MDR regimen or with the newer drug regimen. Serum electrolytes, serum proteins, lipase and amylase, and ophthalmologist's opinion to rule out chorioretinitis and uveitis has to be done if the patient will be receiving newer drug regimen. Pre-treatment counseling is very important prior to treatment initiation. The treatment, as we saw, is for a very long duration. The shorter MDR regimen is for a 9 months duration, while the conventional MDR regimen and drugs for treating other resistant patterns have to be given for a duration of nearly 24 to 27 months. So, it is very important that both the patients and the close family members are appropriately counseled. So, they must be informed about the disease, the mode of the spread of the disease, the treatment that is to be taken by the patient, which includes dosage schedule, the duration for which they have to come, the common side effects of the anti-TB drugs, the importance of regular anti-TB treatment and the consequences of irregular treatment, and how the treatment progress will be monitored and what are the investigations that are essential for this activity. And it is also important to counsel them about the prevention of disease transmission like cough etiquette and avoidance of spitting in the public. The screening of close contacts for TB patients have to be ensured for early diagnosis of TB and appropriate treatment. If the female patient if the MDR TB patient is a female, then there should be discussion about the family planning methods to ensure that the patient is having appropriate contraceptive measures while taking the MDR TB treatment. Supportive care has to be provided, and it is very important to identify and address comorbidities like diabetes, liver and renal disease and neurological disorder. The substance abuse, which include tobacco and alcohol use, appropriate counseling has to be given and interventions have to be planned accordingly. The patients have to be linked to support schemes based on socio-economic status because that plays a very important role in continuum of treatment. Nutritional assessment and support as applicable has to be provided to the patient. The management of drug-resistant TB patients has to be done in consultation with DRTB centers which are present at the district and at the nodal level. The treatment adherence has to be ensured by directly observed treatment, which should be given logically and judiciously. The treatment supporter are also incentivized in the revised National TB Control Program. The information and communication technology by using frequent calls, SMS reminders, IVRs and electronic pill boxes are being explored to ensure treatment adherence. Now let us look at monitoring progress in drug resistant TB during treatment. So, basically it consists of clinical evaluation and laboratory investigations, both to look at the response to treatment as well as to monitor adverse drug events. This shows the different investigations that need to be done as per the treatment regimen that is received by the patient, which may be either shorter MDR regimen, conventional MDR regimen, or a regimen for mixed drug resistant TB, or the regimen for which includes new TB drugs. So, clinical evaluation and body weight has to be done monthly in the intensive phase and quarterly in the continuation phase. So, the smear in case of a shorter MDR regimen is done monthly in the intensive phase and at the extended intensive phase. Whereas for the conventional and for the other regimens, it is monthly from the 3rd month to end of IP or extended IP, and once in 3 months in the continuation phase. So, the culture is also done at similar times where the smear is done for the patient. Drug susceptibility testing would be done in case of positive cultures at the end of IP or extended IP or any time in CP, and extended DST has to be done if any resistance is shown on second line LPA. The serum creatinine has to be done monthly till 3 months, then quarterly till second line injectable is completed. Audiometry as and when clinically indicated till second line injectable is completed, and urine pregnancy test as and when clinically indicated. So, the complete blood count, hemoglobin and the platelet count would be done in shorter and conventional MDR regimen as and when it is indicated, whereas in regimens which include linezolid, you will have to do it monthly in intensive phase and quarterly in the continuation phase. The chest X-ray, the TSH and liver function test would be at the end of IP and at the end of treatment, or as and when it is clinically indicated. ECG in terms of shorter MDR regimen has to be taken at 2 weeks and at monthly and IP, in conventional MDR regimen when indicated, and in the regimen without new drugs or with new drugs at 2 weeks and monthly in IP and as and when it is clinically indicated. Serum electrolytes in case of regimen without new drugs or with new drug regimen has to be done in quarterly in intensive phase and as and when clinically indicated. Serum magnesium, calcium, lipase, protein and amylase will have to be done quarterly in intensive phase if the regimen includes a new drug and as and when clinically indicated. So, in terms of management of H mono and poly resistant TB, the serum urea creatinine audiometry which was initially done as part of pre-treatment evaluation is not now currently recommended because the regimen does not contain the second line injectable kanamycin. The follow-up investigations, the smear has to be done at the end of 3 months and monthly till end of treatment, and the culture at the end of 3 months and end of treatment. The treatment may be extended from a 6-month period to a period of 9 months if there is extensive lesion, uncontrolled comorbidity, extrapulmonary TB, and if the patient is culture positive at the end of third month of treatment. In case of miliary TB, an extension of treatment up to 1 year is warranted. The extension of intensive phase in drug resistant tuberculosis is basically decided based on culture positivity. For shorter MDR TB regimen up to 2 months, for conventional MDR TB regimen up to 3 months, for XDR TB it can be up to 6 months, and for regimen for mixed drug resistant tuberculosis, the extension of intensive phase can be up from 3 to 6 months duration. The regimen for drug resistant TB is for a longer duration, so it is very important that we know about management of treatment interruptions. If the patient misses dose in intensive phase, it has to be completed prior to switching over to continuation phase. Missed doses in continuation phase have to be completed prior to stopping treatment. If the patient misses less than 1 month of treatment during the intensive or continuation phase, that phase has to be continued and the duration of treatment has to be extended to complete the intensive or the continuation phase. If the patient has missed more than 1 month of treatment continuously, in other words declared as lost to treatment, we should repeat the drug susceptibility testing and the treatment has to be restarted based on drug susceptibility profile. In case of bedaquiline, if the patient has missed bedaquiline dose and the duration is for less than 7 days, the regimen has to be continued and the duration of treatment extended to complete the intensive phase. If the missed bedaquiline dose is for more than 7 consecutive days, the bedaquiline dose has to be restarted and the specimen has to be sent for culture. If the dose is missed in the first 2 weeks of bedaquiline, one should not make up for the missed doses and continue the treatment schedule. So, what are the different adverse effects of these drugs which are used to treat drug resistant tuberculosis? We have a separate session on adverse drug reaction and its management. I will briefly mention about the important adverse effects of the drugs that are used for treating drug resistant tuberculosis. So, the aminoglycosides kanamycin and cypromycin can cause nephrotoxicity and ototoxicity. The fluoroquinolone levofloxacin and moxifloxacin can cause arthralgia, dizziness, convulsions, GI disturbances like diarrhea, vomiting and abdominal pain and phototoxicity. In addition, moxifloxacin can cause QTc prolongation. Ethionamide can cause gastrointestinal disturbances which include epigastric discomfort, anorexia, metallic taste, vomiting, hepatitis, hypothyroidism, neuropathy and gynecomastia. Cycloserine can cause confusion, depression, suicidal tendency, insomnia and seizure. Drugs like para-aminosalicylic acid can cause gastrointestinal intolerance, hepatic dysfunction and hypothyroidism. Linezolid can cause myelosuppression leading to anemia and thrombocytopenia, peripheral neuropathy, lactic acidosis and optic neuritis. Clofazimine can cause skin discoloration and QTc prolongation. The new drug bedaquiline can cause nausea, vomiting, hepatitis, elevated amylase and lipase, arthralgia, headache and QTc prolongation. So, these are the various adverse effects of the drugs used for treating drug resistant tuberculosis. So, what is the role of surgery in MDR and XDR TB? So, we saw in pre-treatment evaluation, surgical evaluation is one of the most important investigation that has to be done. So, if the patient has got a unilateral resectable disease and there is absence of response to treatment with effective anti-TB drugs despite 6 to 9 months of regular treatment, in case of morbid complications of parenchymal disease which include hemoptysis and bronchiectasis, or if there is reversion of culture to positive during treatment, relapse after treatment completion, high risk of failure or relapse in case of high degree of resistance or parenchymal involvement, surgical evaluation has to be done and surgery has to be considered for these patients. So, now let us look at the treatment outcome in rifampicin resistance, MDR and XDR TB. So, what is cured? A patient is declared cured if he completes treatment as recommended without evidence of failure and 3 or more consecutive cultures taken at least 30 days apart during continuation phase are negative, including the one at the end of treatment. Treatment completed refers to completion of treatment as recommended without evidence of failure, but no record that 3 or more consecutive cultures taken 30 days apart are negative after the intensive phase. So, both cured and treatment completed constitute treatment success. The treatment outcome as far as shorter MDR TB regimen is concerned. So, cured is treatment completed as recommended without evidence of failure and culture negative at the end of treatment and at least one previous occasion. Treatment completed is completed treatment according to guidelines, but does not meet the definition for cure or treatment failure due to lack of microbiological results. So, these two comprise the treatment success. So, what are the unfavorable treatment outcomes in case of drug resistant tuberculosis? A patient is considered treatment failed if the treatment is terminated or need for permanent regimen change of at least 2 or more anti-TB drugs in continuation phase because of lack of microbiological conversion by the end of intensive phase or microbiological reversion in continuation phase after conversion to negative, or adverse drug reactions or additional acquired resistance to fluoroquinolone or second line injectable. So, the definition of conversion to negative refers to 2 consecutive cultures taken at least 30 days apart are negative. A patient who dies for any reason during the course of anti-TB treatment, the outcome is taken as died. Lost to follow up, a patient whose treatment is interrupted for 1 consecutive month or more for any reason prior to being declared as failure is declared as lost to follow up. A patient for whom no treatment outcome is assigned is not evaluated. Regimen change, a patient who needed permanent change of at least one or more anti-TB drugs prior to being declared as failure. So, the outcome is regimen change for such a patient. These patients have to be followed up after completion of treatment at 6, 12, 18 and 24 months. If the patient is symptomatic during the follow-up period, clinical evaluation, chest X-ray, smear culture and drug susceptibility test, if culture is positive, have to be done. So, if the patient has a treatment success, it is very important that long-term follow-up for at least 2 years is done for these patients. Palliative care is very essential for patients who are chronically ill, especially due to extensive disease, if they failed XDR TB or if they have a mixed pattern drug resistance regimen. Regimen cannot be designed with new drugs or to alleviate the suffering during treatment. So, the palliative care includes respiratory rehabilitation, relief measures from pain and other symptoms, infection control measures, nutritional support, vocational rehabilitation, preventive measures and psychosocial support. So, coming to nearly to the end of this session, we must acknowledge the fact that the management of MDR, XDR TB is very challenging because the current treatment regimen is for a longer duration. The minimum treatment duration is for 9 to 24 months and this can lead to poor treatment adherence. Moreover, there is combination of multiple drugs that the patient has to swallow, which is very difficult for the patient. The drugs have been reported to have poor efficacy and they are also toxic. These drugs are about 4 to 5 times expensive than the cost that is used to treat drug sensitive TB patients. Moreover, no fixed dose combinations are available. So, this is a final slide of my session which shows that drug resistant TB is preventable considering the challenges it poses in terms of management. Because if you see that the factors that contribute to acquired drug resistance can be divided into 3 different categories. From the healthcare provider perspective, it might be due to inappropriate treatment, which is due to non-compliance with guidelines, lack of training, poor patient education, no monitoring of treatment, poor management of adverse drug reaction and poor treatment support. So, it is important that all these factors are addressed to prevent drug resistance. In terms of drugs, it may be poor quality medicines, unavailability of certain medicines, poor storage condition, wrong dosage combination or poor regulation of medicines. So, it is important that the correct combination with appropriate dosage is given for the prevention of drug resistance. From the patient perspective, it might be due to lack of information that is provided, lack of means to adhere to treatment, drug adverse effects, social and financial barriers, substance abuse or dependency, comorbid conditions like HIV and diabetes mellitus, undernutrition and malabsorption. So, all these factors contribute to acquired drug resistance. So, it is very important that all these factors are addressed and drug resistance is prevented. So, the key messages from these 2 sessions are Prevention of drug resistance is a priority. The treatment of drug-resistant TB is less effective, more prolonged, expensive and toxic compared to the treatment of drug-sensitive TB. Minimum treatment duration is for 9 to 24 months duration in drug-resistant TB. The dosage of drugs is based on body weight. The pre-treatment counseling is very important for these patients because of the longer duration of treatment. The monitoring treatment progress and adverse drug events is important, and newer drugs and regimens are warranted to improve the treatment success among these drug resistant TB patients. Thank you for your attention.